Great. So I'm going to try and make it as specific to PACES as I can, but I think it is important that we have a little bit of background knowledge as well. So let's start. So I'm going to start with the anatomy first of all. Now, mitral stenosis is quite a difficult murmur to pick up during the PACES examination because it's a diastolic murmur. And I personally used to find diastolic murmurs quite challenging. So let's talk about the anatomy first. As you can see from the picture, there's a picture of the mitral valve apparatus here. So the mitral valve itself has the annulus, which is the cusp that holds the mitral valve leaflets. And there's an anterior leaflet and a posterior leaflet. The leaflets are attached via the cords, which are chorditendinae, and then the papillary muscles, and then to the myocardium and the endocardium. The issue is that whenever we get endocarditis, for instance, if it's an anterior mitral valve leaflet endocarditis, it does end up affecting our aortic root as well, because you can see from the picture how close the anterior mitral valve leaflet and the aortic root are to each other, and that can cause aortic root abscesses, aortic valve endocarditis, and so on. Also in things like connective tissue disorders, we can have problems with the chorditendinae over the mitral annulus itself, which can lead to stenosis or regurgitation. And then things like acute myocardial infarction can lead to rupture of the papillary muscles, which can cause secondary mitral regurgitation. So I'm going to move forward now. So what are the main causes of MS and MR? So on the left of the slide, you can see this is sort of the normal mitral valve anatomy. And then on the right, you can see there's narrowing of the mitral valve because of many reasons, and that can lead to mitral valve stenosis. The most common cause, especially more so in developing countries or underdeveloped countries, is rheumatic fever. And the strange thing about rheumatic fever is you can get rheumatic fever when you're younger, but the complications such as MS is going to present quite late in life. So that's why it goes untreated for quite a long time after it is initially, after you initially have rheumatic fever. And you can find isolated mitral stenosis after rheumatic fever in 25% of the patients presenting with MS. But in 40% of patients who've had rheumatic fever, they will have both MS and MR. So it's not one pathology. And then we have some non-rheumatic causes of mitral valve problems as well, such as there's mitral annular calcification, there's congenital problems, malignant carcinoid, SLE, which are obviously your connective tissue disorders and autoimmune disorders and rheumatoid arthritis, certain drugs. Then you can have radiotherapy, for instance, if you've had breast cancer and you've had radiotherapy to the chest or lung cancer, then that can affect your mitral valve as well. And then you can get functional, for instance, if you've got narrowing of the aperture, etc., because of age, calcification. So that's another reason. Now I'm just going to stop and ask all of you, if you have any questions, please do shout out before I move on. Okay, fine. So the natural history is quite important here, as you can see. Mitral stenosis usually progresses quite slowly, as I discussed earlier. It has a very long latent period where it can go undiagnosed for ages, basically. And even for several decades, between having rheumatic fever and then actually developing stenosis of the mitral orifice, significant enough to cause symptoms. And symptoms usually start appearing if you do an echocardiogram and you see if the mitral valve aperture, its size, if you measure it, if it's less than 2 to 2.5 centimeters square, that's when patients start becoming symptomatic. And then we grade the severity of the MS looking at the mitral valve area. And if it is less than 1.5 centimeters square, then you can start getting breathless at rest. You can start having orthopnea, PND, and then signs of right-sided heart failure as a result of growing LA, left atrial pressures as well. The 10-year survival of untreated patients, that's quite interesting because you can still have a good survival with mitral stenosis. The main factors determining your survival or your prognosis is the how bad the stenosis is, how tight the mitral valve area is, basically. So for instance, your 10-year survival of untreated patients with MS depends again on the severity of the symptoms. And if you're an asymptomatic patient, so you're minimally breathless at rest, you have on and off maybe some chest pain, you can still survive. 80% of them will have a 10-year survival rate. But those who have significant limiting symptoms, for instance, they have chest pain on minimal exertion, they're very breathless, they have syncope. So their survival rate automatically goes down quite a lot. So it goes down to only 10 to 15%, which is quite a massive jump. And the important thing here to understand is that mitral stenosis not only affects the left side of the heart, it also affects eventually your pulmonary artery pressures and your pulmonary venous pressures. And then when it causes pulmonary hypertension, and that's when things start getting out of hand, and the mean survival is only 3 to 5 years in some patients. Now, just like as I was explaining earlier, by mitral stenosis in isolation, it does not exist in isolation. Eventually, when you start becoming symptomatic, you would have developed other complications as a result of having mitral stenosis. So, for instance, a child had rheumatic fever, had a normal life, they was not symptomatic with it, but then eventually they became breathless, etc. So you would then at that point see that that person's left atrial is enlarged as well, because obviously they're trying to compensate. The left atrium is trying to compensate for the increased pressures. And then the left atrial pressure will cause remodeling of the left atrium. It will lead to left atrial enlargement. It will lead to, and left atrial enlargement is a massive substrate for developing atrial fibrillation. So that's why most of the patients with MS will end up also having AFib. Um, Atrial fibrillation, as we all know, if it goes untreated, you can develop a clot in your LA, and that can cause thromboembolic disorders and strokes, etc. That's one side that's one of the complications of MS, and as you can see in the flow chart, other complications can include pulmonary artery hypertension, pulmonary congestion, and that can cause exertional dyspnea and ultimately leading to increased RV pressure, which can cause right ventricular hypertrophy as well, and right ventricular failure. And then just going to move this out of my way. So as you can see, you can have fatigue, dyspnea, your functional capacity reduces automatically. You can have signs of right-sided heart failure. So for instance, if you have a patient in BitePACES and they're looking sort of fluid overloaded to you, they've got a raised JVP, peripheral edema, RV heave, you would wonder what else is going on. So make sure that mitral stenosis is one of your differentials in mind as well. Again, there's there's reduced exercise tolerance as a result of all these changes that are happening, dynamic changes that are happening in our myocardium and endocardium, and also pressure changes that are happening. So I'm just going to stop here. I think there's something in the chat. So I'm just going to scroll down and make sure. How likely is it to come across MS in BitePACES? So it is not a very common case in BitePACES, but it can come. And I've had a patient in my exam who had dual valve pathology, who had MS and had AR, and it caught me off guard. So I have been a victim of this scenario. So it's not completely uncommon. Yes, it's not very, very common. Right. Just coming back to mitral stenosis. So you can have asymptomatic mitral stenosis, still have severe mitral stenosis where your mitral valve area would be less than 1 centimeter square on your echocardiogram, but you can still be compensating well because you're young, you're fit, your left atrium has not started remodeling yet. Then you can have progressive mitral stenosis where the where the mitral valve aperture or the anatomy, it has started to alter. There's commissural fusion, there's diastolic doming of the mitral valve leaflet, so sort of they dome into your left atrium because of the increased LA pressures. And then you can have symptomatic severe MS, and that's when your LA is enlarged, your pulmonary artery systolic pressures are above 30 millimeter mercury, you would have reduced exercise tolerance, breathlessness, and so on. So it is quite a hemodynamic evolution of symptoms. It's not just that there's annular calcification or rheumatic heart disease that's affected your mitral valve and caused it to become thickened and stenosed and tighter. It's also how that tight valve is actually affecting the LA, then the pulmonary vasculature, and then of your heart. That's when you start becoming symptomatic. Right. So as you can see here, breathlessness is the first presenting symptom. You can feel very tired and fatigued, uh, shortness of breath, chest pain, reduced exercise tolerance. So all these, and then other complications like strokes, they can develop as well. General examination. So, for instance, if you're in the exam situation, you can do your examination. You don't jump onto the precordial examination straight away. You do look at the facies, the hands, the blood pressure, pulse, etc. So, just from the end of the bed, have a look at malar facies. They can present with lupus erythematosus, but you can have it with MS as well, purple pinkish patches on your cheeks. And it happens because of cutaneous vasodilation. Pulse can be normal, low volume. Normally, it's sinus. If you have atrial fibrillation, it can be irregular. Uh, if you have signs of right-sided heart failure, your JVP will be raised. I don't think you need to comment on the A wave and the V wave and the JVP to complicate things, but you can make a fair course judgment that your JVP is elevated or not. Then obviously they would have crackles in their lungs if they are in fluid overload. So just a few quick sort of examination hints that you can pick up. Again, if you put your hand on the precordium, you would appreciate an apex beat. It will be non-displaced, and if you're very sort of good at picking up your murmurs or your apex beat, you can hear a tapping first heart sound. You would have a diastolic thrill at the apex when you move the patient in the left lateral position. And then, of course, if you put your palm on the precordium on the left parasternal area, you can also feel a heave. You can feel a palpable P2 in your pulmonary area. So the palpable P2 can happen with patients who have tetriomphalate and they've had tetralogy repaired and they have had a pulmonary valve repair. I have a patient in BitePACES who I teach who's had a pulmonary valve replacement who has a palpable P2. But then these sort of patients can also present with MS. You can have a palpable P2 if you have pulmonary artery hypertension. So that's something to just sort of bear in mind. Right. Any questions so far? Mm. I'm not really good at looking at the chat because I've got multiple things going on in my screen. So if you have any questions, please shout out. I'm just going to move forward now. Right. So on auscultation, just moving forward for your examination. So you've done a bedside examination. You've had a quick sort of head to toe. You've looked at the patient. You've done your inspection. Then you've done your palpation. Right now, you wear your stent. You put your stent on the precordium, and you hear a loud S1. Right. So fine. So why would you have a loud S1? You would have a loud S1 because of your increased left atrial pressures. And what happens is that the mitral annulus, the aperture becomes very stiff. And that's when it or the LA pressure. So the left atrium, the blood in the left atrium is going to push against a very tight, very narrowed mitral valve at the end of diastole. And that's when the mitral valve is closing, and that's where it's very stiff and it closes with high pressure. It opens with high pressure, and that's where you hear a loud S1. And obviously, you can have a loud P2, sometimes a palpable P2 as well, because of your pulmonary artery hypertension. That's when the pulmonary valve is under pressure and it's closing under increased right-sided pressures. So opening snap, again, you can hear it at the apex when the leaflets are still mobile. And then diastolic murmur, you can have a low-pitched rumbling mid-diastolic murmur. Again, it's very tricky to pick up. So you need to find these patients and examine them to sort of get that mid-diastolic click, just to develop that skill set during examination. Again, it's best heard with the bell. And my trick is to move the patients in the left lateral position, because any pathology with the mitral valve, whether it's MR, MS, you know better than I do, it's better heard in the left lateral position. And the severity of the MS, it correlates with the duration of the murmur and not the loudness of the murmur. So you have to see how long the murmur is lasting for, not how long it is. Okay, not how loud it is, sorry. Okay, so you've done the examination, you think this chap has MS, and then you move towards the invigilator, and then they ask you a couple of theory questions. So what would you find in an ECG? They can ask you that question if you think one of your differentials is mitral stenosis. And you can say on ECG, you can find either normal sinus rhythm, or you can have atrial fibrillation. You can have a P mitral, you can have signs of right ventricular hypertrophy. Chest radiograph, again, as you can see, you will have straightening of your left heart border and double right heart border as well, which you can see on the right. Again, this is all because of your enlarged LA and right ventricular hypertrophy. The cardiac silhouette itself, it can be normal. You can have signs of pulmonary congestion on the chest X-ray, batwing appearance, pulmonary edema. Then you would also, so basically you'll do an ECG, you would do a blood pressure, you would do a chest X-ray if needed, if indicated, if the patient is breathless. And then obviously the most definitive is doing an echocardiogram. And if you're planning to proceed towards repairing the mitral valve or replacing the mitral valve, you would do cardiac catheterization to understand your right-sided heart pressures and your pulmonary artery pressures, basically. And right, so echocardiogram, it's useful initial diagnosis. It helps determine how bad the MS is, what sort of follow-up is needed, and what is the suitability for a percutaneous balloon mitral valvuloplasty, and any concomitant valve lesions, because it is important to understand whether this is an isolated valve problem or whether there are other valvular pathologies as well, like stenosis, aortic regurgitation, etc., which you can technically repair at the same time in some cases or replace. So in a 2D assessment of an echocardiogram, now this is a transthoracic echocardiogram. You will look at the leaflets, see how mobile they are, how thickened they are, are they calcified or not. And then we don't only look at the leaflets and the aperture, we look at what's under the mitral valve. So for instance, what is happening to the chordae? Are they fused? Is there any shortening or fibrosis or calcification of the chordae? And these things all determine ultimately how likely or what procedure will best suit the patient. We also look at the mitral valve area. And then again, we don't forget the left atrial dimensions that are very important. So these are some echocardiographic images. So for instance, on the left, you can see, on my left at least, there's that's your right ventricular at the top. Then you have the interventricular septum here, LVOT, and then just the mitral valve itself, the anterior leaflet, which is towards the left ventricular outflow tract, towards the aortic root, and then you have the posterior leaflet as well. So these are certain views you can get on the echocardiogram. So I'm not going to go into these details because I don't think they're relevant to your exam. So yes, so then like we have to measure the severity of the mitral stenosis by looking at the mitral valve area by checking the pressure gradient across the mitral valve. So how much is the pressure in the LA? How much is the pressure in the LV? Uh, and then we do some measurements like the pressure half time, etc., and the mean gradient. So again, I'm not going to bore you with this because for your exam, that's not important. So just a few things again. Why do we do a esophageal echocardiogram, a TOE or a TEE? It just provides a better look at the mitral valve, basically, rather than a transthoracic echocardiogram. It gives us a better idea of the subvalvular anatomy, assesses the degree of associated MR. And like I said earlier, you cannot only have MS, you can also have MR. So that's also important to understand. And again, to see if there's any LA thrombus or left atrial appendage, which is again something we look at through the esophageal echocardiogram. In some patients who have bleeding disorders and who have an enlarged left atrium or atrial fibrillation and MS or whatever reason they have an enlarged LA and they cannot have anticoagulation, then one of the options is called left atrial appendage closure. I think the surgeons, they just close the left atrium up, they tie it down, and then that sort of prevents clot formation as well. Exercise testing is another test we do. We don't do it so much in England. I've noticed it's more common in sort of the other European countries and in the East. It is useful in evaluation of patients with symptoms when the resting study is discrepant. So, for instance, you've done an echocardiogram and you think that the mitral stenosis is not so severe enough, but the patient is very much more symptomatic than what the echo is telling you, then you can proceed towards exercise testing as well. It can be helpful to determine actually the functional capacity and the hemodynamic impact of the stenotic mitral valves in the setting of exertion. And we measure the mean mitral valve gradient and the pulmonary artery pressure here. So that's another sort of, so in the exam, they can ask you what sort of tests you can do to assess the severity of the MS. You can say you can do an echocardiogram, transthoracic, transesophageal, and you can also do exercise testing to assess the functional capacity or the impact of the MS on the functional capacity of the patient. So then moving on to cardiac cath, like we said earlier, cardiac catheterization is another diagnostic test we use, which can be helpful in assessing the severity of the MS when the clinical and the echocardiographic assessments are discordant. So for instance, the patient has MS but is more breathless or is having more chest pain. So you can do cardiac catheterization. In that case, you will look at your pulmonary artery pressures, your RV pressures, and so on. And it's an invasive assessment. And the mean mitral gradient is most accurately assessed during this procedure. Medical management. So the examiner can also ask you, so they can ask you about the test you would do for an MS, like we've discussed earlier. They can also ask you how you would manage a patient with MS. So I'm going to stop here because I've been talking non-stop and I don't want to sort of give the impression that I don't want to hear you. So if you have any questions, please shout out. I'm waiting. No questions? Okay. So medical management obviously is aimed towards prevention of recurrent traumatic fever, treatment of MS and its associated complications, and just, excuse me, monitoring the disease progression. So we do need to have some form of follow-up for patients with MS. like we would with any other valvular pathology. In some hospitals in England, we have valve clinics that are run purely by echocardiographers and cardiac physiologists who do echocardiograms. They are trained well enough to interpret the echocardiograms and then offer follow-ups to the patient. So not all valve patients need to be under consultant care in some hospitals. They can be followed up purely in the valve clinics or the echocardiography clinics. So asymptomatic mitral stenosis, like we discussed earlier, you don't need to really treat those patients. You can do an annual echocardiogram for them. So, but you can, if they're asymptomatic, you can even do an echocardiogram every 3 to 5 years for mild mitral stenosis. And then if it's becoming moderate, you would do it more frequently, like 1 to 2 years. And those who have rheumatic MS, they should receive penicillin prophylaxis. As per the guidelines, infective endocarditis prophylaxis is not recommended. For instance, if you have mitral stenosis and you're going for a dental procedure, you don't need to have antibiotics before that. Or for instance, before any surgical procedure. So that also depends on your pre-op anesthetic assessment, but generally we wouldn't give antibiotics, and obviously you wouldn't be a surgical candidate if you've got severe MS, but generally you wouldn't give IE prophylaxis. Anemia and infections again should be treated promptly. It's no rocket science that if you have MS, you can become very unwell very quickly, because infections increase your oxygen demand. You can end up having dyspnea, chest pain, anemia, again, oxygen supply mismatch. So you need to treat those accordingly. Anticoagulation, again, to prevent systemic embolization in patients who have MS and AF. Or prior history of embolism in the LA cavity or the LA appendage. In MS with sinus rhythm with severe LA enlargement, where the LA size is more than 55 millimeter, or spontaneous contrast, if you see it on the echocardiogram, you can still offer them anticoagulation. Now, so this was all about just the basic common management, but if you have symptomatic severe MS, what would you do? You can give them oral diuretics, and you can advise salt and water restriction like we would for any heart failure patients if they're breathless or symptomatic. You can give them beta blockers, non-dihydropyridine calcium channel blockers. They may improve their exercise tolerance, especially in patients with AF. Like we would with so for instance, if you're treating a patient with angina, we would give them beta blockers or diltiazem or verapamil. Similarly, we can do that for MS patients as well. Atrial fibrillation, again, you would give them beta blockers for rate control. You would give them anticoagulation as well. You can also give them digoxin if the blood pressure is low and you can't really push bisoprolol. So, and if you have concomitant LV dysfunction, then you can digitalize the patient with digoxin as well. So these are a few things. And if you are planning to cardiovert these patients, if they are in uncontrolled AFib, obviously, or very fast AFib, then you need to make sure that they are anticoagulated properly. Again, obviously, if they're hemodynamically unstable, then anticoagulation, then cardioversion can be done in emergency situations, and we can ignore how long they've been anticoagulated for because they are hemodynamically unstable. But generally, if they are stable, their blood pressure isn't dropping, then you need to make sure they're well anticoagulated. Otherwise, they'll end up having a stroke. Okay, so just a couple of things like how we treat mitral stenosis. We can do a percutaneous balloon mitral valvuloplasty, pretty similar to our TAVIs. You don't really have to open the chest wall up, so just something we can do in the cath lab. This is a video. I'm not going to go into it, of how you do EMC. Again, if you've got rheumatic mitral stenosis, like we discussed earlier, you can have a severe MS, and progressive. So very severe is when your mitral valve area is less than 1 centimeter square. Severe is when your mitral valve area is less than 1.5 centimeter square. Okay. You can have very severe MS and you can still be asymptomatic, but if you are symptomatic, then we can do a valve and you have a favorable valve favorable valve morphology, then we can offer them a percutaneous balloon mitral commissurotomy as well. But then it depends on certain things as well. So, for instance, if you have a young patient, you would, and they've got very severe MS, a very, very narrow mitral valve area, you would preferably do an MVR on them, right? But then this sort of changes. So, for instance, if you're pregnant and you've got severe MS, but you're not symptomatic with it, cardiologist can monitor you. But if you're pregnant and you've got severe MS and you've got NYHA 3 or 4 heart failure, then we can offer you percutaneous interventions as well, which we do in cardiology. So it does happen in real life. So it all depends on your age, on your functional class, on the severity of the MS, on how symptomatic you are with it, etc. Right. So not going to. So complications again, which you can be questioned about in the exam. Sorry, just give me 1 second. Yeah, so the mortality is not very high. It's 1 to 2%. But then again, this more severe your MS is, your mortality exponentially reduces. You can become more symptomatic with it. You can get cerebral emboli. You can get cardiac perforation. Again, that can lead to tamponade in 1 to 2% of patients. You can develop MR as well, which can be severe enough to require surgery. So these are a few complications of mitral stenosis. And then, like we discussed in the beginning, it can affect your aortic root. So you can get aortic abscesses as well. And aortic root abscesses, or it can affect your bundle of His. So you can get high degree AV blocks as well. So small residual ASD in approximately 5% of patients, but most close or decrease in size over 6 months. Rarely it is large enough to cause heart failure. And you can get restenosis as well. There was some data from National Heart, Lung and Blood Institute Registry of all functional classes. It showed that 84% survival rate at 4 years after procedure, but advancing age, high functional class, presence of AFs, smaller initial mitral valve area, higher pulmonary artery pressure, and substantial tricuspid regurgitation, they were associated with poorer long-term outcomes. And then the valve can restenose as well. Surgical approach again recommended when obviously your bare metal valve is not available or is contraindicated and the surgical risk is acceptable. Coexisting disease and other valves that necessitate surgical intervention. So, for instance, young patient with mitral valve stenosis, aortic valve regurgitation, aortic valve stenosis due to a bicuspid aortic valve, and you want to do a dual valve replacement, you can do a surgical approach, or when you have mixed mitral valve disease. So these are all things. So I do have a patient in BitePACES who has two metal valves, aortic valve and mitral valve. So like again in PACES, you can get dual valve replacement, and dual valve replacements are not uncommon. They're quite common. And most of them are aortic and mitral valves. Right. Surgical approach, closed mitral valvotomy. Don't need to go into the details. You just need to know the names. It's performed through a thoracotomy, done in developing nations, etc. So I'm not going to go into these details because I don't think the examiners would. And you can do an open mitral valvotomy as well, preferred over closed mitral valvotomy due to direct visualization and done with the aid of CPB, basically. I think it's a sort of a balloon valve that we implant. Mostly performed in patients whose mitral valves are too distorted or calcified for BMV or who have an LA thrombus. So we try and just open the valve up and then put in a new metal valve in. Again, like we discussed earlier, if you have combined, MS and moderate to severe MR, you would prefer a mitral valve replacement rather than a mitral valve repair or a transcutaneous approach. If you have extensive commissural calcification, you have severe fibrosis or self-valvular fusion of the mitral valve aperture. So if, for instance, if there is calcification or fusion or fibrosis below the mitral valve aperture, you would prefer to do a surgical approach, a mitral valve replacement, put in a metal valve, rather than do a mitral commissurotomy or a valvuloplasty. Again, those who've undergone previous valvotomy, because sometimes you need to redo the metal valves after 20, 30 years. So these are a few reasons. And operative mortality for isolated MVR ranges from 3 to 8%, which increases to 10 to 20% with NYHA class 4 symptoms. So we try and intervene early. We don't wait for patients to go to NYHA for heart failure, because the mortality increases post-operatively and intraoperatively. Post-procedural follow-up, they undergo either percutaneous or surgical procedures. They should have their baseline echocardiogram preferably within 72 hours post-op. Those who have AF, the warfarin should be started 2 to 3 days after the procedure. Until then, we keep them on unfractionated heparin. Clinical examination should be done at least once a year. And then no firm guidelines have been developed on how often a follow-up echocardiogram should be done post-operatively. It all depends on the trust you're working in, on the local guidelines, and what the consultants follow. So again, these are some guidelines, class 1, class 2 indications. So again, like class 1 indication, TTE is indicated in patients with signs or symptoms of MS to establish the diagnosis and quantify the hemodynamics. And TEE, which is your esophageal echocardiogram, which should be performed in patients considered for percutaneous mitral balloon commissurotomy. So any patient you are considering to have a percutaneous mitral valve commissurotomy or PTMC should have a transesophageal echocardiogram. That's class 1B indication. We don't only rely on a thoracic echocardiogram. Again, exercise testing with Doppler invasive hemodynamic assessment is also a class 1 indication. What I wanted to show you basically is the one with pregnant females that is quite interesting. Here. So pregnancy and valvular heart disease medical therapy. So for instance, you have anticoagulation. It should be given to pregnant patients with MS and AF unless it is contraindicated. So that's one thing. Use of beta blockers are required for rate control. It is reasonable for pregnant patients with MS in the absence of contraindications if tolerated. Class 2A indications. So class 2A means, okay, you can give them, but you have to have a risk and benefit discussion with them. You need to have close monitoring. And the use of diuretics, again, it is reasonable for pregnant patients with MS and heart failure symptoms. 2B indication, not 1. And then ACE inhibitors and ARBs, obviously they're contraindicated because they're highly teratogenic. So it is a class 3 indication. You do not give it in pregnant patients. So you have to make sure their anemia is corrected. They're monitored closely. You plan C-section early, and all these sort of things. And ideally, sometimes I've seen that women, they don't even know they have mitral stenosis till they get pregnant. It's only when they start becoming so out of breath that they end up with an echocardiogram or they end up in E&E, and that's when, okay, so you have mitral stenosis. And then that's very tricky to manage. Okay. Valve intervention is recommended before pregnancy. So if you are known to have MS and you are a female planning to have a family, it's recommended that you do get your valve repaired or replaced before you're getting pregnant, especially if you're symptomatic and you've got severe MS, right? That's a class 1 indication. Percutaneous mitral balloon commissurotomy is recommended before pregnancy for asymptomatic patients with severe MS who have valve morphology favorable for percutaneous mitral balloon commissurotomy. So you can give them both the options. It depends on the age of the patient, the surgical sort of assessment, etc. But ideally, the bottom line is that any mitral stenosis severe enough to be causing symptoms, it should be treated. But if you are asymptomatic and you still have severe MS and you are planning to get pregnant, you should still have the mitral valve repaired because it will get worse when women are pregnant. So that's fine. Let's move forward then. Valve operation should not be performed in pregnant patients with valve stenosis in the absence of severe heart failure symptoms. So if you are pregnant, you have MS, but you're not too bad with it, you can still have a safe delivery. We don't normally intervene. So that's that. And then valve intervention is reasonable again for pregnant patients with severe MS, and valve morphology not favorable for percutaneous mitral balloon commissurectomy, only if they are refractory and YHA class for heart failure symptoms. So again, this is a very complicated situation, very unfortunate situation. So there's a pregnant female who's got severe MS. She's very symptomatic. And for instance, she has a severely calcified mitral valve aperture. You cannot do a balloon mitral valve commissurectomy on these patients. What other options do you have? You watch them, but this woman is becoming very breathless. She's an NYHA fluoride heart failure. She's edematous. Diuretics obviously are not helping her. Beta blockers are not helping her. What do we do? I mean, you're hitting. She's in heart failure. She's on dobutamine or your vasopressors and your inotropes, etc. Then you do end up operating on them, but it's a very high risk surgery. It's a risk versus benefit discussion. You do plan delivery early, so it's an MDT approach. It's not a one-man show. You do need the cardiologist and the obstetricians on board. And then valve operation should not be performed who have valve stenosis in the absence of severe heart failure symptoms. Like we've discussed earlier, it's a class 3 indication. We monitor them. All right, thank you. I'm going to ask you if you have any questions. Please shout out. Oh, there's something in the chat. Let me have a look. In AF, are we aiming for rate or rhythm control in MS? Both. Both, basically, because with atrial fibrillation, you don't want the patient to start becoming decompensated. So if they have a heart rate of 80 to 90 at rest, fair enough, you can start them with a low dose of beta blocker because they can get breathless sometimes. But if they are sort of tachycardic, then like we discussed earlier, you would digitalize them or give them beta blockers or calcium channel blockers. Rhythm control. Well, unlikely that we go for a rhythm control approach because by the time MS presents, their LA is already enlarged. What are you trying to achieve by rhythm control here? What are you trying to achieve by cardioversion? Because if you cardiovert the patient, it's likely that the AF will come back. It is likely that eventually they would need surgery or some form of intervention for their MSS, unless they're hemodynamically unstable and you're thinking of about a medical cardioversion by amiodarone or an electrical cardioversion by a direct device. That is a different situation altogether if they are hemodynamically unstable, but rather we would go for rate control and monitor them annually because eventually their LA will dilate, the AFib will come back. So I don't think we're really achieving much here by rhythm control. So you mentioned cardiac perforation as complication of MS. What is it secondary to, please? So cardiac perforation can happen as a result of severe calcification of the mitral valve. It can happen as a result of chordae tendineae rupture. It can happen as a result of your papillary muscle rupture, which can be a complication of severe MS. Pretty much the same, really. Just I think the approach is slightly different.